Thank you for listening to the Health and Safety Podcast. I am Michael Wong, founder and executive director of the Physician-Patient Alliance for Health and Safety. In an earlier podcast this year, I spoke with Dr. Jeffrey Vender about respiratory compromise. Dr. Vender is chairman of anesthesiology at North Shore University Health System and chairman of the Clinical Advisory Committee to the Respiratory Compromise Institute. Today, we are speaking with Dr. Frank Overdyk, who is an anesthesiologist at Roper St. Francis in South Carolina, about the necessity of assessing and monitoring patients for respiratory compromise. Frank is also a member of our board of advisors and organized the two conferences on opioid-induced respiratory depression for the Anesthesia Patient Safety Foundation. So we're honored to have Frank speak to us today about this critical patient safety issue. This clinical education podcast is made possible by educational grants from Medtronic and EarlySense. Welcome to the podcast, Frank.
Thank you, Michael.
For the listeners not familiar with you or your work, could you give us a brief introduction about yourself?
Sure. I'm a professor of anesthesiology. During my career, has been studying the effects of pain medications, specifically opioids, on breathing. In my research, I became aware that there are thousands of patients dying unnecessarily from too much opioid pain medicine. So my passion is finding ways to reduce this preventable harm from patients who receive too much pain medicine and stop breathing, and eventually reduce that to zero.
We're talking today about the necessity of assessing and monitoring patients to detect respiratory compromise. There's often a sentiment that it's only minor surgery, and yet serious adverse events and even patient deaths have occurred following routine surgeries. And here I'm thinking of celebrity cases like Joan Rivers, kids that have their teeth extracted, or even elderly patients that go in for knee surgery. Why is it difficult to predict how a particular patient will react to the administration of an opioid or other sedative agent?
Well, let me address your first question. Some minor surgery can be quite painful, such as hand surgery, for instance. And for those conditions, opioids are still the most effective way to treat moderate to severe pain, even for minor surgery. Treating pain is a good and necessary thing, since uncontrolled pain will delay your healing and causes suffering that's obviously avoidable. However, what is not appreciated by patients and by some doctors and nurses is that a patient's response to a quote-unquote standard dose of morphine, for instance, can vary up to 30-fold. And what that means is that if I give 100 patients the same dose of morphine, 10 milligrams of morphine, about 90 patients will get some level of pain relief, some better, some worse, and breathe adequately. But there may be one or two patients who slow their breathing or even stop breathing. And it is very difficult because of that variation in effect to predict which patient will be the one who stops breathing when you turn your back on them for 10 minutes. So I always say there's no safe first dose of opioids. There's just a starting dose. And it is critically important that the patient be checked regularly to see how the patient responds, and then adjust your doses accordingly.
So would you recommend titrating and starting with a lower dose first and then titrating up?
Well, certainly most hospitals have pre-printed order sheets that have these doses. And yes, that's where you can start. Like I said, there's a starting dose. And to be able to treat most patients, you want to start somewhere in the middle. But you have to be cognizant that that patient may be the one who's all the way on the left of the spectrum in terms of sensitivity and may react much more seriously to that medication than your typical patient.
So in your experience, are there some patients who are more at risk, or certain procedures for which the risk of respiratory compromise is higher?
Certainly, and that's not just in my experience, but that is widely published in the literature. So certain patient conditions and certain procedures place them at greater risk for respiratory depression. And the conditions fall into two categories. Those patients who tend to obstruct their airway when they get sedated and have their pain treated, and those patients who have conditions that make them more susceptible to respiratory depression. So let's talk about the first group. That first group includes patients who have obstructive sleep apnea, which is more often than not even diagnosed, so what we call occult obstructive sleep apnea. Morbidly obese patients are also at greater risk of airway obstruction. So those are two patients who, by virtue of their conditions, are at greater risk. The second group includes the elderly, frail patients, or patients with lung or kidney disease. And then there's the last group that we call opioid-naive patients, patients who've never really had opioids. They can be exquisitely sensitive to the effects. And so, as you can see, the response to an opioid is somewhat complicated and unpredictable. And that's why we see this 30-fold variability of patients' responses. Now, there are also certain procedures that increase your risk of respiratory depression. Those include any surgery on the airway, the chest, the upper abdomen, or prolonged surgery or surgery requiring high doses of pain medicines in the operating room.
So are there tools or checklists that are currently in existence that may help clinicians recognize opioid-induced respiratory depression?
Sure. Well, we essentially use two types of tools currently. The first tool helps us evaluate a patient's risk for respiratory depression and relies on their past medical history and their physical attributes may put them at increased risk. So I just mentioned patients with sleep apnea or cold sleep apnea, morbid obesity, COPD, as well as patients who are tolerant to opioids. The second tool that we use are the assessment tools that we use on the ward to measure this effect in a quantitative way. These are sedation scores, pain scores, and records and trends in vital signs. Records and trends in vital signs are extremely important. Now, unfortunately, in our busy day on the ward, we don't always use these tools, but it's been shown that practitioners who use these tools reliably and take the time to do this have a much greater chance that their patients will be safe.
No, that's great. But is there a danger of relying upon these tools as a predictor or using these tools to, in a sense, triage patients?
Certainly, triaging patients implies that there's a group of patients who are not at risk, and this is unfortunately false. We have plenty of examples of tragic cases of patients who do not have any of these disease conditions I mentioned or these physical attributes that put them at higher risk, but they died on a hospital ward, typically behind a closed door, from unrecognized opioid-induced respiratory depression. These are patients are healthy patients who come in for elective surgery and are typically opioid naive. So no tool will be 100% successfully in identifying every patient, but these tools are targeted to identifying many of those patients.
That's great caution or warning to clinicians treating patients with opioids. The number of patients undergoing conscious sedation is increasing. Do you think that these patients could also be at risk for opioid-induced respiratory depression?
So I have to laugh sometimes at the prevalent use of conscious sedation. It's, I think, a misnomer. Most of the conscious sedation I see are actually patients who are unconscious and unresponsive to verbal or tactile stimuli. And the more accurate term for that would be moderate procedural sedation. If your provider says they're going to give you conscious sedation, be ready that you may be completely knocked out, so to speak. These patients who undergo moderate procedural sedation, this procedure is done in a closely monitored setting by a dedicated provider, such as a trained nurse, a nurse anesthetist, or an anesthesiologist. They should be using continuous oximetry and capnography monitoring, as that is now the standard of care for procedural sedation cases in all states. So certainly if you're undergoing procedural sedation or conscious sedation, some people may say, make sure that you have a dedicated person watching you and using these oximetry and capnography monitors.
So the risk really is every time you're giving a patient some kind of opioid or some kind of sedative, the risk is going to be there no matter what you do or what procedure you're undertaking.
Well, yes, the risk is highest for people who get intravenous medications of these sorts, the pain medications, and certainly when they're doing a procedure on you where you're having potentially painful stimuli, there's that risk. This discussion is really about those patients who've had their surgery, who are now on a ward, somewhere behind a closed door potentially, and can go unmonitored for large periods of time.
What's wrong with the current standard of care for monitoring patients, which in most places is taking vital signs every 4 hours?
Critical respiratory depression can develop in less than an hour, even as fast as 10 to 15 minutes. But it's not something that you see within the first minute after you give an intravenous opioid dose. So it can be somewhat insidious. Checking a patient every 4 hours will miss the condition. The result is that we may find the patient dead in bed, and no amount of resuscitation will help a patient who has stopped breathing and is in full cardiopulmonary arrest for more than 15 minutes. We have rapid response teams in most hospitals that respond to these emergencies on the ward, but unless they get there within 5 minutes of a patient taking their last breath, there's very little hope of rescuing the patient. If you have a cardiac arrest on a ward, your chances of surviving or not having a lifelong brain injury are 30% or in that ballpark. So measuring your vital signs every 4 hours is really a very outdated standard. There's really no evidence that suggests that every 4 hours is a good time. It's just something we have carried over through the years. It may be 30, 40 years old, but it's an antiquated monitoring standard. Patients in our hospitals these days who are high acuities deserve better monitoring.
I often hear from hospitals something like, yes, we continuously monitor our patients. We've attached a pulse oximeter. Do you think that this type of patient monitoring is sufficient?
So the pulse oximeter is a device that checks the amount of oxygen in the blood and is a good way to make sure that your patient is getting oxygen and a sufficient amount of oxygen. It's a fairly reliable and accurate monitor. But if you check this monitor only every 4 hours, which we call spot checks, you may miss that serious episode of respiratory depression that can result in cardiac arrest. So if you swing by the patient's room every 4 hours with a pulse oximeter, I don't think it necessarily helps you monitor the patient. It's been shown that these spot checks, oximetry checks, often involve awaking a patient who may be sleeping, and that the reading that they get then is actually artificially high. In other words, it's a falsely high value. So spot checks with an oximeter have been deemed by the Joint Commission and other patient safety organizations as being dangerously misleading and really a bad practice.
Have you found capnography monitoring a better early indicator of respiratory compromise?
Well, let's go back to some of the physiology here. So oxygen monitoring can be a good early detector if the patient is not receiving supplemental oxygen. But most of the patients in our hospitals do so for one reason or another. So you mentioned capnography, which is the measuring of end-tidal CO2 or carbon dioxide that we breathe out. And in the sense that capnography will show us whether we're actually moving air in and out of the body, it is a very good, more accurate monitor of a patient who's breathing, whereas a pulse oximeter may be much later. That being said, there's no high-level evidence that it's earlier, but there are some studies undergoing right now that suggest that it may help in the earlier detection of conditions related to respiratory depression and other forms of respiratory compromise.
Now, we've talked about the 4-hour spot checks. Is there a more dangerous time during this period that a patient can be susceptible to respiratory compromise?
Sure. The dangerous times for respiratory depression undetected basically fall into two categories. The first relates to when the pain medicine is given. So when a patient receives their first dose of opioid, or there's an increase in the dosage because their pain is not well controlled, you have to watch the patient very carefully. And I would say at least every 15 minutes for the first hour, you need to be checking on that patient. The effects of morphine won't manifest for an hour to an hour and a half after you give the intravenous dose. Or if you give a more potent opioid such as fentanyl, it may happen earlier. So that's very important when you initiate the dosages or you increase the doses that you watch the patient carefully. The second most dangerous times of the day relate to the times of the day and week. Nighttime is a vulnerable time because the patient is sleeping and their airway may become obstructive more easily. That is just one of the features of sleep, is that we may relax our tongue and the other muscles in our airway. It may obstruct, and if you have a predisposition such as obstructive sleep apnea, now you could get into trouble. So nighttime is a dangerous time because of the conditions, but also because on night times and weekends, we typically have less vigilance on a ward. Our staffing is usually lighter. The experience of the staff on those times is usually less. And as a result, our vigilance is less. So night times, weekends, and around the timing of the medication is extremely important periods that you have to be very alert.
Some clinicians triage patients and continuously monitor some and not others. This may be understandable from a resource allocation point of view. What do you think of this practice?
So yeah, we touched on this a little bit earlier. So triaging or performing a risk assessment on all your patients to see if they fall into a high-risk category of respiratory depression is now a common practice at most hospitals and advised by the Joint Commission and others. As you said, this is done because there may be limited resources of providers and equipment to monitor riskier patients continuously. Like I mentioned before, you do put a small group of patients who have no risk factors at risk for undetected respiratory depression. And we know how that story ends, possibly with a cardiopulmonary arrest and death. That is not common or even likely, but happens to thousands of patients we take care of every year in the U.S. Ideally, I believe all hospitalized patients in 2018 deserve at a minimum some form of continuous monitoring. Triaging is acceptable, and it'll catch those patients at the highest risk. But if we have a zero tolerance for preventable harm, then we should aim for continuous monitoring of all patients.
And you're certainly correct, because most of the patients' stories that have appeared on our website are with opioid-naive patients, and they have unfortunately suffered adverse events or more likely death because of that. So it's a great point, Frank. How expensive is it for a hospital to continuously monitor patients, and how expensive is it not to monitor patients appropriately?
So economic analyses of the cost of continuous respiratory monitoring have been done. The cost of technology is a moving target, since the cost will come down as adoption becomes more widespread, and there are different pricing models as well. You can price by disposables. So there are creative ways to finance continuous monitoring. But there are estimates that the daily cost of continuous monitoring of a patient, for example, with a pulse oximetry, is on the order of $20 or $30 a day. This does not include the cost implications of staff workflow and some of these other softer costs, indirect costs. Rolling out new technology may initially require more resources. There are many institutions that have now adopted continuous monitoring, where a couple of things have happened. The institution finds it to their financial benefit. The providers find it to their clinical benefit, in that they are vocal about removing the technology. And obviously, what we cannot ignore is the human cost of this. And the human cost of a preventable harm or preventable injury or death to a patient is not just to the patient and their families, probably the most important cost toll, but also to the providers, because this is a very traumatic thing to happen to somebody.
Absolutely. Hospitals often tell me they don't have a problem, and I think you just alluded to that. They haven't had an adverse event or death occur, and they don't continuously monitor the patients. What would you say to these clinicians and hospital executives?
I believe if you check the quality and outcome data that hospitals report to CMS and other regulatory agencies, there's not a hospital in the U.S. that I'm aware of who has not had a cardiac or cardiopulmonary arrest on a ward in a patient who walked into the hospital for an electric procedure and has few of any medical problems. So I'm focusing on this category because these are the patients who should not be having these preventable deaths. And they fall under a reportable category events called patient safety indices, or PSIs. Failure to rescue is one of those, death in patients of low comorbidities. There are a number of PSIs that we track now. A significant number of these PSIs are related to opioids and undetected critical respiratory depression. So if a hospital administrator tells you they don't have a problem, I think they are simply not informed on their outcome data, or they're in denial, one or the other.
So what do you think are the biggest impediments to incorporation of continuous monitoring in everyday clinical practice?
We've come a long way in that people recognize now that there's a need. Initially, when we started this 10 years ago, people said we don't have a problem. And we now have enough metrics and enough evidence that we do have a problem. There's a reluctance to change things. Medicine is a very difficult industry to get changed. We are a long way away from being a high reliability industry where we have very high quality. Our quality is not reliable. There's a great variation. So we are reluctant to change. But the champion institutions who have adopted this have overcome the barrier, the financial barrier, the workflow barrier. The evidence showing that this is a good thing to continually monitor is accumulating. And obviously you need a center of gravity of research to be able to start to prove that. But it makes sense that we shouldn't have anyone dying unnecessarily in a hospital, and that we can go a long way towards earlier detection as well. We are overcoming these barriers. Some people are a little more reluctant, some institutions are more reluctant, but I think for the most part, people are recognizing that there's ways to do this that makes good clinical sense, good human sense, and good financial sense.
So do you have any last words of advice for clinicians looking to keep their patients safe?
Well, I'd like to go back to some of the sentiments that resulted from the 1999 report by the Institute of Medicine's Air is Human, where they showed how much preventable harm we have. And I think as we go into our clinical day every day, we need to make a commitment to take good care of all our patients, not just most of them. And if you do so, you will recognize that the extra effort required to keep them safe may come at a small expense to you. You may have to respond to a few false positive alarms during a shift, or you may have to spend a little time educating the patient what you do to keep them safe with a monitor or with the pain expectations or how they can help in that care, but not having to sit and explain to a patient's family why they died a preventable death or have a lifelong anoxic brain injury is well worth that investment. We need to have really a zero tolerance for preventable harm. And monitoring is part of that, but there's other things we can do. Your organization and others are taking the lead in that. So it's an extremely worthwhile effort.
Thank you, Frank, for being on this podcast. And hopefully clinicians, hospital executives, and risk managers listening to this podcast will continuously monitor the patients and improve their patient safety. Thank you, Frank.
Thank you, Michael.
This clinical education podcast is made possible by educational grants from Medtronic and EarlySense.